All right. Hello, everyone. Thank you for being here today. Welcome to this GAP MASLD presentation. My name is Lavinia Iordache. I am a physician assistant with hepatology affiliated with University of Miami. And we are here to learn how to identify patients with advanced liver fibrosis, and more specifically, how to differentiate between stage 3 and stage 4 fibrosis, because as we will see, this is a determining factor in how we approach management. So we will go into a clinical case. Let me see if I can move the slides here. Nothing is happening. Let me see. Okay, maybe just a little slow. All right. So here's the QR code, a little bit more information that you can scan and look at the online material. All right, so we will go over a clinical case and discuss the use of non-invasive tests or NITs for accurate staging, highlighting how different fibrosis stages lead to key differences in the clinical pathways and influence patient prognosis overall. So our patient here is a 55-year-old Caucasian man, let's call him Sam, who is undergoing evaluation for elevated liver enzymes and evidence of steatosis on imaging. He endorses fatigue, which is nonspecific, otherwise no significant symptoms. His past medical history here includes obesity. We know that his BMI is 33. He has diabetes, hypertension, hyperlipidemia, sleep apnea, and he is on medications listed here: lisinopril, rosuvastatin or Crestor, ezetimibe, Orzidia, and dapagliflozin or Farxiga. His physical exam reveals an obese abdomen, which sometimes makes it challenging to palpate abdominal viscera. However, we can appreciate hepatomegaly, which is due to significant fatty liver infiltration in some cases. Important to mention that for Sam, we see no signs of portal hypertension, no splenomegaly, no appreciable ascites or cutaneous stigmata of liver disease. So laboratory examination here, including his vitals, which are pretty unremarkable. Blood pressure seems well controlled. He's afebrile. He has a good respiratory rate. And focusing on the labs, we spot that his transaminases are elevated up to 2.5 times the upper limit of normal. We want the ALT to be below 30 for a man. Bilirubin is 1.17, it's borderline, platelet count is preserved, coagulation function is within normal limits, and the serologies were non-diagnostic, though some were slightly abnormal, such as a ferritin of 780, which is of course an acute phase reactant, but we know that transferrin saturation is normal at 30%, essentially ruling out iron overload as an etiology. And the ANA titer was 1 to 80, which can be due to an epiphenomenon in the background of steatosis. It doesn't necessarily mean the patient has autoimmune hepatitis, as the other serologies like the smooth muscle and everything else were negative. Viral hepatitis markers were all also negative. So we have already established that our patient Sam has several risk factors for MASLD. Given the above workup, alternate etiologies of liver disease were confidently excluded. So the natural next step is to use NITs, right? How would you further test this patient, and how would we stage this patient? So we will use non-invasive tests. Where are we? Sorry, this is the slide. So we would use non-invasive tests. The first one would be a FIB4. It is the easiest one to calculate. The score was 3.1, which falls into the high risk for advanced fibrosis category. Naturally, we do a second NIT fiber scan, which confirmed F3 fibrosis with a median liver stiffness of 11 kilopascals. And in addition, it also provided a more exact assessment of the degree of steatosis in the liver, which in this case was severe based on a control attenuation parameter cap of 262. ELF, or Enhanced Liver Fibrosis Test, is a blood test that measures 3 biomarkers involved in collagen homeostasis: hyaluronic acid, procollagen 3 aminopeptide, and tissue inhibitor of metalloproteinase TIMP1. A score of 9.8, as seen here, is considered high. Our patient had a score of 9.9, which correlates with presence of advanced fibrosis. So in this case, all NITs actually matched quite well, and there was no discrepancy between the results, which we will see is not always the case. So therefore, no additional testing would be required for our patient SAM. However, whenever appropriate, especially when there is concern for advanced liver fibrosis, other tests can be performed, such as MRE and even a liver biopsy in select cases. So how do we treat the patient? Can I pause for a second? I updated the slides, but these are not the updated slides. Do you want to switch them?
Yes, I'll pull this up right now. I'm so sorry.
Yeah, because I added some more stuff in there.
I had both up.
Do you want me to start over?
It's up to you, whatever you feel most comfortable.
Well, I think this is where it becomes important. So, but for the sake of like continuity of presentation, I don't know if you want me to go over the material again or kind of pick up where I left off.
We could, let me just make sure. And do these are the same. I'm so sorry about this. Let me just.
I should have looked at them before I started, but I just kind of assumed.
Sorry, it's my bad.
Communicated this morning.
Okay. Okay.
So can you edit the this little break that we had, or
Yeah, we'll edit this out, no problem.
Okay.
I'm just gonna put it in. Presenter mode. Okay, and then if I'm gonna give you back. Okay, if you want to just jump ahead to where you were, that's totally fine.
No problem. So let me see where I was. So, okay, so I'll go back to, okay. So in this case, all NITs actually matched up quite well with each other. There was no discrepancy between results, which we will see is not always the case. But for our patient Sam, since we were pretty confident in the assessment of his fibrosis, no additional testing would be required. However, whenever appropriate, especially when there is concern for advanced fibrosis stage 3, other tests can be performed, such as MRE and even a liver biopsy in select cases, especially when you are trying to determine whether the patient should be treated with pharmacotherapy or not. So how do we treat this patient? How would we monitor our patient SAM? What is the plan of care that we would implement? So, of course, we know that lifestyle management, including diet, exercise, with the goal of achieving a minimum of 5% of body weight reduction, is at the core of MASLD management. And we can refer to that topic for further details. But in essence, caloric restriction, aerobic exercise, strength training were all shown to be beneficial in improving steatosis. Quick mention here on Mediterranean diet, which was accredited by all the major groups as being the most beneficial for improving liver steatosis. We can consider pharmaceuticals such as GLP-1 agonists, which are available and should be considered for select cases, such as patients with morbid obesity, limited mobility, who cannot exercise very much, cases refractory to lifestyle changes. And we see this a lot in practice when patients are doing the best that they can and they don't have the desired results. Or those with underlying comorbidities such as diabetes, although we often find that many opt for this approach in the absence of all of these factors just because they want a faster result. Monitoring for HCC is extremely important in our MASLD population, as MASLD accounts for 35% of cases of HCC worldwide. And research shows that 15 to 46% of the patients with MASLD-related HCC do not have cirrhosis. Special attention should be paid to older male patients, as they are believed to have an increased risk for HCC. The difference between the male and the female population is attributed to the anti-inflammatory effects of estrogen, as well as the protective effects against carcinogens in women. So talking about carcinogens, tobacco is a known risk factor for many types of cancer, and HCC is no exception. And in addition, tobacco has been associated with more advanced fibrosis in patients with metabolic-associated steatotic liver disease. Alcohol exposure, and particularly heavy alcohol use, increases the risk of HCC by 66% in patients with liver disease from any etiology. But there seems to be a synergistic effect between obesity and alcohol use in the development of HCC. Also important to mention that diabetes seems to increase 2 to 4-fold the risk for HCC, and this risk is higher in patients with uncontrolled diabetes. Of course, we cannot ignore the genetic predisposition, which also seems to play a role in the progression of MASLD and also development of HCC, specifically PNPLA3, MBO8T7 polymorphism, and also these can be found in patients without cirrhosis. Definitely more research is needed in this area. So how do we need to specifically screen our patient for HCC, given that he has stage 3 fibrosis? Well, screening for patients with F3 is not currently recommended by ASLD. Their guidelines suggest that screening should be done in cirrhotic patients only. However, EASL recommends that F3 fibrosis patients should be considered for screening based on individual risk assessment. In other words, does the patient have additional risk factors for HCC aside from the level of fibrosis? Therefore, we have to take into consideration all of the above talking points. So for our patient Sam, we know that his hemoglobin A1C was 7.1%. Therefore, his diabetes is not really optimized. Borderline, right? He doesn't smoke or drink alcohol in excess. However, he has an elevated BMI corresponding to grade 1 obesity. And this is important when we consider the modalities that we employ for HCC screening because of the body habitus and the thicker subcutaneous adipose layer. Ultrasound can be unreliable and potentially miss up to 41% of HCC diagnoses. If you recall, our patient had an obese abdomen on exam. Therefore, he would be better served by undergoing a CT or an MRI. though we do have to acknowledge that these more invasive tests come with drawback of contrast administration, higher cost, and sometimes insurance denial. We do check an AFP level, specifically AFP L3, which has a higher accuracy in early HCC detection in patients with and without cirrhosis. So we live in some exciting times in the realm of hepatology because finally we can consider pharmacotherapy for MASLD patients. Rezdiffra was conditionally approved in March 2024 in conjunction with diet and exercise. And it is a partial agonist of thyroid hormone receptor beta in the liver. It stimulates lipophagy, inhibits lipogenesis, essentially reducing hepatosteatosis. The doses are 80 milligrams per day, which is most common, and 100 milligrams per day can be used in patients who weigh over 100 kilograms. The primary endpoints of treatment are NASH resolution by at least 2 points with no worsening of fibrosis or reduction in fibrosis without worsening of steatosis. And how do we monitor patients who are on treatment? So basically, we use labs and repeat NITs at 6 and 12 months to assess the response. We also have to monitor for side effects, which seem to be dose-related, and they were mainly GI symptoms, diarrhea, and nausea, which were usually mild and resolved within 3 weeks of treatment initiation. So in regards to assessing treatment response, an ALT reduction by 17 points or a 20% improvement or normalization of ALT and or a reduction in the level of fibrosis as evidenced by a drop in the stiffness score by 30%, both are considered positive outcomes. And in these cases, treatment should be continued for at least 1 year. Of note that changes in the CAP score alone are insufficient to determine treatment response until further data are available. So monitoring the labs shortly after starting Rezdiffra is recommended as well to ensure there is no drug-induced liver injury. There haven't been many cases reported in the clinical trials. We have to keep in mind that there were some early increases in the AST and the ALT values in the first 4 weeks of treatment, generally mild, less than 1.5 times the baseline. And they resolved by week 8 in the absence of treatment discontinuation. So patients continued on the medication, and nonetheless, the enzymes went back to their baseline. So most patients can safely continue on treatment. You can elect to check the labs at 4 weeks, just keeping in mind that this may happen. Continue to monitor until week 8. If they don't normalize completely, you may consider waiting until week 12 before you make a decision about continuing or discontinuing the treatment. So now we will consider the same patient case with slightly different NIT scores. We basically have kind of the same labs almost, except for the platelet count that is now 128,000. The creatinine is 1.3, total bilirubin is 1.4. Otherwise, all values remain the same, and there are no new findings on physical exam. Okay, so talking about the NITs, FIB4 is still 3.1, same as before. FibroScan is now 21 kilopascals, liver stiffness, which is suggestive of F4 fibrosis or cirrhosis. CAP is 245, not much change there. There is no significant steatosis. And we actually see this a lot in practice because fibrosis is a result of ongoing inflammation, which in the process leads to what we call burnt out steatohepatitis as seen on biopsies. The ELF score is also higher at 11.4 kilopascals. So now based on these NITs and taking into consideration taking into consideration that patient has now thrombocytopenia, there is real concern that fibrosis may have progressed to F4, though liver disease is still well compensated. And the staging will define the treatment options available to patients. And even though the clinical trial is still ongoing, Maestro phase 3, for patients with cirrhosis, for the time being, they are to be excluded from treatment with resmetirom. So is further testing necessary? In this case, basically for staging purposes, for our patient, we have enough information to confidently say that the patient has reached stage 4 cirrhosis. However, this patient definitely needs cross-sectional imaging to evaluate the liver parenchyma and exclude hepatocellular carcinoma. And in the process, if you get like a triple phase CT or an MRI with contrast, he may be found to have any evidence of portal hypertension on imaging, which can also confirm his cirrhosis diagnosis. So we're looking for recanalization of umbilical vein, portal flow changes, collaterals, intra-abdominal varices, caudate lobe hypertrophy, of course, nodularity of liver contour, etc. So how do we manage F4 fibrosis? How would we monitor this patient differently than a patient with stage 3 or lower? We definitely make the same recommendations for improving lifestyle choices with emphasis on alcohol avoidance in order to prevent decompensation and mitigate the risk for HCC. Because HCC is one complication you don't want to miss, and therefore we must do appropriate screening for it every 6 months with alternate studies, because as we saw earlier, ultrasounds may potentially miss up to 41% of HCCs in patients with significant steatosis. Patient education becomes all the more important at this stage. I found that spending time initially to go over the potential complications enhances patient compliance. The more informed and aware they are about the risks involved, the more prepared they are to recognize early signs of decompensation and seek care, and the more inclined they are to undergo testing such as repeat imaging and endoscopies. Patients, of course, need screening for esophageal varices. You can use the FibroScan score here as well as the platelet count. For our patient, the platelet count is below 140,000, so he would need an endoscopy for screening. We cannot use the Baveno 6 criteria in this case. So if I was to add something to this slide, it would be patient education, which I believe leads to an overall improved experience for the patient as well as survival. So if we compare the two scenarios as we have the NIT's results here side by side, what stands out is that FIB4 alone can be unreliable. And in this case, it overestimated the degree of fibrosis in the F3 patient case here on the left side. So by pursuing other NITs, such as ELF and FibroScan, we were able to adequately stage and treat this patient with Rezdiffra. He would otherwise have been missed, and this option would not have been available to him. So FIB4 alone should not be used to exclude patients from treatment. A second NITs should always be considered. So here we have, how do we manage these two different patients and how do we compare? So patients with F2 and F3 are eligible to receive Rezdiffra, whereas F4 patients must be excluded, at least for now. And in regards to the NITs that we use to differentiate between F3 and F4, we start with an FIB4, right? It's the easiest, the fastest to calculate, and the fastest to interpret. I sometimes order an ELF, but not always. I find myself using the ELF test whenever there is a doubt about the stage, though I should mention that For me, the deciding NITs I usually employ is an imaging test, such as a FibroScan or an MRE. Even though these may not be readily available at all centers and might not be covered by insurances, in which cases we can use an ultrasound with elastography. That can also be helpful. There has been some concern that they may be underestimating the level of fibrosis, so that's why you have to consider multiple options. Even though we are moving away from performing liver biopsies for staging purposes, in a smaller number of cases, these may still be the most appropriate path to an accurate diagnosis, especially when competing etiologies must be ruled out. And it can help in inconclusive cases when a definite staging must be achieved. When is HCC screening important? We already discussed the ASLD and EASL recommendations earlier, but I will reiterate that even though there are no specific guidelines for HCC screening in non-cirrhotic patients, I would say that the answer to this question is always due to the increased risk of HCC in this MASLD patient population. We can consider the additional risk factors on an individual basis, but as a general rule, I aim to order routine imaging for stage 3 patients as well. And I think that's all we have. I want to thank you for your attention and your time today, and I'm happy to answer any questions.